Thank you very much. It's really a great honor to be here, and I want to thank Dr. Dukas for the kind introduction and the hospitality. He gave me a nice tour of your beautiful city this morning and treated me to a very nice dinner yesterday evening. I also want to thank the Cheng family for sponsoring this wonderful lecture series. I think, as we were talking earlier, having the opportunity to have conversations like I hope we have today is an important part of keeping the values that he stood for alive in modern medicine. So the title for my talk, I guess I should change it over here. The case for shared decision making. Hopefully some of you have already been convinced about the case for shared decision making, but I chose this because although shared decision making is a concept that's been around for a while, it's kind of come back into vogue, particularly in sort of policy circles, which we'll get to in a few moments. And I in particular focus on ethical, clinical, and policy perspectives to sort of paint a picture for you of why shared decision making today has become an important part of the fabric of future healthcare. Now, by way of disclosure, I want to let you know I'm on the board of directors for an organization called the Foundation for Informed Medical Decision Making, and the foundation produces high-quality, evidence-based resources to help patients make medical decisions, and also does some advocacy work around the importance of shared decision-making in clinical practice. So it's a really interesting group, which I'm happy to talk about later. My specific goals for today are to have you be able to analyze the state of shared decision-making in practice. And I'll share with you some of my own work as well as the work of others that show us some of the work that lies ahead in this area. To describe the relationship between shared decision-making and clinical outcomes, and to discuss strategies so that when we all leave today, we'll be able to think about concrete things you can do, whether you're a student or in practice, to enhance shared decision-making in medicine. So the case. Now, along the way, I'm going to make 5 major points. The first is to review and just touch on the strong ethical, compelling ethical foundation for shared decision-making. Second, to contrast shared decision-making with the legal concept of informed consent. And those of you in practice know some of the limitations of informed consent as a concept and in practice. And I think shared decision-making is a better alternative to informed consent. I'll show you some of the evidence that supports the role of shared decision-making in practice, and then share with you some of the evidence that illustrates the gap between the ideal of shared decision-making and the reality of practice. And finally, to tell you a little bit about how the policy and practice environment is now much more favorable to really moving forward in this area than ever before. Okay. So, first of all, the ethical foundations. And we can start with sort of the question, why ought we be doing shared decision-making? Now, I don't know if anyone knows who that gentleman is up in the corner there. The sort of dour, kind of stern-looking fellow. Some of you who have done some training in philosophy or ethics may recognize him. That's Immanuel Kant, noted moral philosopher. And of course, Kant is known to be one of the key figures in a branch of normative ethics called deontology, that is essentially the idea that you determine whether an action is right by appealing to some moral rules, that we have certain axioms, rules that guide moral conduct. And you had the categorical imperative, which is the idea of how you could develop those moral rules. Well, I'm not going to talk about Kant today, but now you have a picture of him, you can imagine what he looked like. But rather, I'm going to focus on the degree to which rules, or the idea that shared decision-making is right because it's the right thing to do, is an important place to start. Now, the term shared decision-making probably can be traced to a President's Commission report that was published in the early 1980s. And as you might recall, in the 70s and 80s, there was a series of commissions of ethicists, really in the early stages of bioethics as a discipline, looking at contemporary problems in biomedicine and research and others. And this particular one focused on healthcare decisions. And the President's Commission said then that the ethical foundation of informed consent, the ethical foundation of informed consent, not the legal foundation, we'll come to that soon enough, can be traced to the promotion of 2 values, personal well-being and self-determination. Now we call that beneficence and respect for autonomy, but the concepts are the same, a balance. They went on to say that ethically valid consent is a process of shared decision-making based on mutual respect and participation. not a ritual to be equated with reciting the contents of a form that detail the risks of a particular treatment. Now, I think back to my first experience with informed consent. I was a third-year medical student, starting my first day of surgery, and one of my first tasks was the resident turned to me and it said, "Braddock, go down there and get a consent from Mr. Jones for his cholecystectomy." So like a good, dutiful third-year medical student, I dashed off, got almost all the way down the hall before I stopped and thought to myself, what does that even mean? So I went back and sheepishly asked, just get him to sign this form. Tell him what, all the stuff that's listed on here and get him to sign it. And that concept of consent is still very much alive in practice, and this is where the President's Commission was trying to have a departure from that very kind of disclosure-oriented legal framework and a framework which is much more bidirectional. Now, what are the components of shared decision-making? Shared decision-making includes an explicit conversation about the patient's desired role. Some patients really want to participate a lot, others would rather defer. A discussion about the nature of the problem, the alternatives, the pros and cons, any uncertainties, the impact of the decision on the patient's life, to probe the patient's understanding to make sure they have an adequate understanding to help them be an informed participant. See if they want to solicit input from trusted others, spouse, family, primary care physician, etc., and eventually to elicit the patient's preference. Now, to put this in context, I'm going to share with you an example. It's just completely by coincidence that I chose prostate cancer screening, because you've just heard this week that the U.S. Preventive Service Task Force has now created another controversy around prostate cancer screening. We won't necessarily talk about that today, except maybe in the Q&A. But this is an example from some research we've done in looking at actual practice, how physicians actually talk with patients, with men, about prostate cancer screening. I'll put up on the side there the criteria that I just mentioned and invite you to listen and just think about, what do you think of this physician's conduct of this shared decision-making conversation with this gentleman? And also just how does this compare to usual practice? And hopefully this sound will work fine.
Screening for prostate. Do you have any questions about that? No, she answered everything. Many years ago, my sister and my brother died of cancer, and I would, I'm not going to make the same mistake I did. He had a stroke because my mother and my brother had a heart attack, and I was thinking, well, it's not going to happen to me again. Sure. So I will take it on and get certain losses.
Okay. Well, again, we'd like to have the ideal test to say this is going to know 100% sure. We don't have an ideal test. But we're going to mammogram works pretty well. It tells us a good amount of information about the risk of breast cancer. For prostate cancer in men, we do two things. One is a rectal exam, the other prostate, to see if there's an increase in size. The other, and that's known to be pretty helpful in figuring things out. The other thing is to do the PSA test, the blood test. PSA test, though, is controversial. We don't really still know whether it works or it doesn't work. Well, we don't know. It's hard to judge what the PSA means. Sometimes it can be slightly elevated, and it means just there's nothing going on. Sometimes it can be normal, and there could be something going on. But it's not 100% accurate sort of test. So I think you would recommend it as a test that people have done, and then if it's abnormal, we can kind of look at it and say, well, we should do this, we should think about this. If it's normal, I'd say, well, that's good. If it doesn't tell me 100%, then it makes me feel a little bit safer. So we're getting that PSA test? Yeah. All right, I'm going to hold up and do the rectal exam today. I'll let us do both on the same day. We'll do the blood test today and do the right.
So in case you couldn't hear the dialogue that well, essentially the patient has mentioned that he's concerned about cancer because there's been some cancer in his family, and the doctor proceeds to tell him some information about the PSA and then says, so you're okay with doing that. And you can think for yourself about whether that meets the kind of model that we're describing. And time permitting, we'll come back to this example towards the end. So the shared decision-making concept, this ethical foundation, part of it is this President's Commission notion, which was described in the early 80s. A related area is the concept of patient-centered care. And patient-centered care is a construct which has also now become kind of front and center in practice. Health systems are competing to try and be more patient-centered, to have better patient satisfaction, the patient experience to be better. And there's a long tradition of patient-centeredness in family medicine, and Dr. Dukas and I were talking about this over dinner. One aspect of being patient-centered is finding common ground. That is the idea of exploring together with the patient your perspective as the physician and their perspective as the person with the condition, and trying to find a common ground and moving forward, whether it's about diagnostic tests or treatment. The Institute of Medicine has opined on this question of shared decision-making and equated it or made it an important part of quality. Quality is also an important construct in modern healthcare. And the Institute of Medicine said good quality means providing patients with appropriate services in a technically competent manner, with good communication, shared decision-making, and cultural sensitivity. So there's a number of streams that you can look at that provide a foundation that say we should do shared decision-making because it's the right thing to do. The second reason to do shared decision-making is because it's a superior alternative to informed consent. And I've already illustrated to you, I think, a little bit of that. But it's, I think, helpful to know a tiny bit about the history of informed consent. So informed consent as a legal construct really arose out of common law traditions, initially around battery, the idea that it was to prevent unwarranted touching, and eventually evolved into theories of negligence. But it began, I think many theorists will point to this case from 1914 as one of the early cases that articulated the idea of informed consent. The case involved a woman who was about to undergo what's called an exam under anesthesia. She had uterine fibroids, and in order to get a better characterization, they needed to anesthetize her to be able to do a thorough examination. But the patient said to the physician, whatever you do, don't do a hysterectomy, because I want to talk about it before we make that decision. So they went and did the exam under anesthesia, found the uterine fibroids were quite extensive, and decided that they should go ahead and do the surgery. They did a hysterectomy. Patient filed suit, and it eventually wound up in the courts. And this quote has resonated in informed consent work since that time, that every human being of adult years and sound mind has a right to determine what shall be done with his own body, and that a surgeon who performs an operation without his patient's consent commits an assault for which he is liable for damages. The legal cases that followed over the next decades really were more about articulating what the physician needed to tell the patient prior to that consent. And one case in particular where the phrase informed consent was first used actually involved my own institution. I'm not particularly proud of that, but... And this is a case in which a patient had undergone an angiogram of their aorta, and as a rare complication, it had caused an artery to the spinal cord to become blocked and led to paralysis. And the courts opined in that case that the physician not only had the obligation to get the patient's permission, but to give them at least some information about the potential risks before getting that consent, and hence the term informed consent. The subsequent cases, and I'm not doing justice to this history, were more about how much information. It started off with the notion that physicians should provide enough information that's more or less the same as what physicians usually provide, the so-called professional standard. Well, that didn't last too long because quickly the public and the courts realized that what physicians tended to provide in the way of information was oftentimes inadequate, and it evolved to the so-called reasonable person standard. The trouble with informed consent as a legal doctrine is this emphasis on disclosure, that primarily the physician's job is to tell the patient a bunch of stuff, go consent Mr. Jones for his cholecystectomy, and get a signature. So when you contrast shared decision-making with informed consent, you find consent as a unidirectional process, physician disclosing alternatives, risks, and benefits, and a patient voicing or signing agreement, versus shared decision-making as a bidirectional conversation, a process of shared decision-making based on mutual respect and participation. And in fact, in legal scholarship now, there's this notion coming out of shared decision-making being called perfected informed consent. perfected informed consent. That is taking the old legal notion of informed consent and trying to enrich it with this bidirectional kind of dialogue. So that's how shared decision making is superior to informed consent. So what about the evidence? So there's another picture for you. This is a guy with a little bit less scary sort of expression. Anyone know who that is? And no, it's not Benjamin Franklin. That's Jeremy Bentham, known for his work on utilitarianism, a branch of normative ethics that says that the rightness of actions is determined by consequences. And this way of thinking is actually very in line with medical thinking, evidence-based medicine. If something is judged to be effective, it's because there's evidence behind it. So we have to answer the question, does shared decision-making fit in this model? Do we have evidence that shared decision-making makes a difference? Well, first, let's look at what patients think. And there's a large amount of literature around the question that shows that patients prefer shared decision-making. In surveys and various types, typically between 2/3 to 3/4 of patients prefer shared decision-making, in this case, when compared to making decisions pretty much on their own versus leaving them pretty much to the physician. The vast majority choose shared decision-making. And this study looked at patients' preference to receive information and be given choices, even though lots of people say, I want to be given information, I want to be given choices, but I'm going to trust my physician to guide me toward what's the right choice. And this finding goes back for many years. Even in the late 80s and in this study in the mid-90s, patients predominantly prefer shared decision-making to other models. There's also growing evidence that shared decision-making can enhance outcomes. That is, the idea of involving patients in decision-making gives them more buy-in to what you're deciding to do, and then actually can translate to better healthcare outcomes. So, improved adherence to asthma medications, improved adherence to medications and outcomes in depression, improved knowledge about heart disease leading to better outcomes, improved satisfaction and improved performance in people with mental disorders, and even better blood sugar control and better quality of life and outcomes in diabetes. More recently, there was a Cochrane review, and you're all familiar with the Cochrane collaboration doing evidence-based reviews of different technologies and treatments, and they actually did one on shared decision-making. In this case, decision aids. Decision aids are typically evidence-based materials put together to provide patients with balanced information prior to decision. It might be a decision aid about knee replacement surgery. It might be a decision aid about mastectomy versus lumpectomy for a woman with breast cancer. Oftentimes they're accompanied with a DVD which has testimonials from patients as how they've thought about decisions. So these decision aids have been studied. And as you can see, there are 55 different randomized controlled trials, 55, that demonstrate the positive impact of shared decision-making on knowledge, risk perception, comfort, participation, people remaining undecided, and people making appropriate choices in line with their values and preferences. So one of my colleagues once remarked that there probably aren't too many things in medicine that have been proven by 55 randomized controlled trials. And this is one of them. So there's a solid ethical foundation, referred to informed consent. There's evidence, a lot of evidence. What about this gap that I mentioned? And this has been a focus of a lot of my work over these past years since my fellowship, and it's been really interesting. Now, I'm going to tell you about one study and then share with you some of the other findings that we've come across. So one of the bigger studies we did was basically the approach is to go into a physician's practice, and with the permission of the physician and the patients, we audio tape the visits. And then we're able to analyze those audio tapes to look for evidence of good informed decision-making, good shared decision-making. This particular study was done in Oregon and Washington with mostly about half and half primary care physicians and surgeons. We had a pretty well-educated patient population, but we looked at over 1,100 different office visits and 3,400 medical decisions. Now you might ask, how did we decide if the decision-making was complete or not? Well, we trained our coders to listen to these tapes and use the criteria that I mentioned earlier to look at the adequacy of shared decision-making. We also realized that shared decision-making, all those elements, was not a one-size-fits-all. And so we had focus groups with patients and physicians and came up with the following kind of scheme. Essentially, we found that we could sort of think about decision-making along a continuum from very straightforward decisions, like the decision to check your cholesterol, do a routine laboratory test, where the amount of information the patient needed and the amount of conversation needed was much less than on the other extreme before having major surgery. And in between there were certain decisions that had more complexity than, say, just getting a cholesterol check, like a new medication, that benefited from having a more substantive discussion. So we used these definitions. We categorized each of those 3,400 medical decisions in one of those categories and had our coders say how many of these elements were discussed. And here's what we found. What we found is that for the basic decisions around, getting a cholesterol check or a blood count to check for anemia, only 17% of the time were those just two things mentioned to the patient. Just 17%. None of the intermediate decisions met the criteria. And 1 out of 213, we rounded it up to 1%, of the complex decisions met the criteria. Overall, if you lump them all together, it was 9%. 9% of the time, the physicians did an adequate job informing the patient at a very minimum level to allow them to participate in decision-making. 9%. Now, you might be thinking, well, they must have been talking about something. And this is a breakdown by each bar represents one of the criteria for shared decision-making for the basic, the intermediate, and complex decisions. And what you'll notice, the tallest bar, the nature of the decision, was the one that was the best. The physicians would say, I'm giving you a new prescription, or we need to decide if we're going to do that hip surgery, or what have you. Physicians were pretty good about at least telling the patient what they were going to do. That's the good news. The bad news is that pretty much everything else was very low. And in fact, if you accept the premise that the central role of shared decision-making is promoting the patient's understanding so that it can be an informed participant, you see that understanding, exploring to find out if the patient understood, was the lowest. And this finding has persisted across a number of studies that we've done. A couple of other studies, and we've done a lot of this work in different areas. In colorectal cancer screening, we found in a primary care population, only on average, one out of the 7 elements of shared decision-making was used. And in a more recent study looking at prostate cancer screening, again before the current controversy, physicians, like what you heard in that tape, said lots of things, but typically less than 3 of the 9 elements for prostate cancer shared decision-making. So this, although that first study was done in the late 90s, even today we find the same gap between the ideal of shared decision-making, for which I've articulated, I hope, a strong case, ethical, empirical, legal, and the actual reality of practice. The most recent of these studies was the so-called Decisions study. This was a national survey of over 2,400 patients and asked them to report on how doctors were doing in shared decision-making. They asked them if they had a recent visit with a physician, a recent decision, and they asked them a series of questions, including, who initiated the decision? Who made the decision? Did the physician discuss pros and cons? Did the physician ask about your preferences? And I won't go into the details, but I'll give you a few examples. So blood pressure medications. Very few of the, very low percentage of times was that decision brought up by the patient. That makes sense. Patients don't usually come in and say, hey, I'd like to be on another blood pressure medicine. Sometimes they do. Usually that's initiated by the physician. And as you can see, a pretty decent proportion of those decisions were shared. Physicians did a pretty good job discussing the pros, not so much on the cons. And this is a theme that we see in shared decision-making around balance. And only about less than half the time did they actually ask the patient if they had any preferences. Breast cancer screening, a little bit more of that raised by patients, a little bit less physicians making the final decision. Again, pros discussed, cons not. Rare to ask preferences. Now you might be thinking, well, wait a second, with breast cancer screening, is there really any downside to breast cancer screening? And we've actually encountered this in some of our work promoting shared decision-making for breast cancer screening. And just to digress for a moment, there are a number of issues related to breast cancer screening that a woman should ponder. Probably the most important example for those of you who have gone through breast cancer screening is the notion of a callback. A callback occurs when the screening mammography shows some unusual finding for which the woman needs to be called back for a diagnostic mammogram. Now, that's what happens, but it turns out that there's a very high percentage of women, about 30 or 40%, who at some time will be called back. Well, what happens to the callback? There's worry, there's anxiety, there's a cognitive burden on the woman. And it's not that that's a reason to not do it, but it's an important thing for the woman to know before she goes down that path. So this is an example of the kinds of things that we promoted that should be discussed so that patients can have information. Joint replacement, again, brought up by patients, not shared as much as it should be. Pros discuss, cons not. We're now seeing in the news about some of the potential long-term downsides of hip replacements in terms of wear down of device, cement, etc. So it's important to have balance. Okay. Well, I promised we'd talk a little bit about the policy and practice environment. And this has been an area that's been very interesting in the past several years, particularly during the healthcare reform debate, and actually is part of the current Accountable Care Act. And I want to say a few words about that. I would start by saying that the way health policy folks think about shared decision making is they start with the notion of the ethical imperative that we talked about earlier. They think about this concept of perfected informed consent. They're interested in having enhancements to the patient experience, and they know patients want to be involved in decision making. And in fact, many health systems are embracing shared decision making, in large part because they see market advantage. Now, that's maybe not the reason I would want them to seek it, but if it works, we'll take it. It's also been put forth as a way to bridge health disparities, and there's some emerging evidence that involving patients through using shared decision making can reduce health disparities in utilization of healthcare services. And the last and maybe most controversial thing is whether shared decision making could help to lead to more conservative utilization of surgical interventions. And I want to say a couple of words about that. So this last picture, that's a gentleman known by the name of Jack Wenberg. And Professor Wenberg at Dartmouth is most well known for his work on practice variation. In fact, the map on the right there is one of the maps from the so-called Dartmouth Atlas. The Dartmouth Atlas is a analytic tool that shows patterns of practice variation for different conditions. That one happens to show joint replacement surgery. And it shows, for example, that in some areas of the country, rates of joint replacement surgery may be 5 to 10-fold higher than other areas. Atul Gawande wrote about this in his well-known New Yorker piece about a town in Texas versus a town in Minnesota with wide variation in practice. Wenberg and his colleagues have studied practice variation, have tended to divide the causes of practice variation into 3 broad categories. One is practice variation that's led by guidelines, it's led by evidence. So when you have good penetration of guidelines, you may have higher rates of utilization of screening or preventive measures when you have low penetration. There's also supply-sensitive care. So for example, it's well known that if you build more CAT scan facilities in a town, you'll do more CAT scans. If you have more hospital beds, you have more admissions. So there's a supply driver. The third one is what they call preference-sensitive care. That is where variation, these kinds of variations that we see, are driven by the physician's preferences but not informed by the patient's preferences. And this has led to the notion that shared decision making, by informing patients and elevating the role of patient preferences in decision making, may actually reduce practice variation. And this has been studied, and there's some emerging evidence which I'll show you one example of. And this was a paper that was in the New England Journal of Medicine last year. It was a randomized trial of shared decision making using a combination of decision aids and telephone coaching for over 170,000 patients in several different health plans. The shared decision making was accompanied by coaching around self-care and behavior change. And what they found was with the shared decision making approach as opposed to usual care, they were able to lower costs by $8 per member per year. Now $8 is not a lot, but the cost of the intervention was only $2. You multiply that across the health system, it's a substantial amount of money. Some of the areas in which they were able to save, you can see inpatient hospitalization was a major area. So in other words, by giving patients information, they might decide that the intervention being suggested by their physician is not something they really wanted to have when they learned more about it. And that cut down on hospital days, cut down on other costs. Now the challenge with this argument for shared decision making is it feels a little bit uncomfortable for those of us who are advocating to move from saying, well, it's the right thing to do, it's a moral imperative, well, it's going to save you money. So it's an area that's a little dicey right now, but it has informed what's happening in the policy arena to a great degree. And in fact, the Affordable Care Act has 2 sections particularly devoted to shared decision making, informed by all the arguments I've laid forward for you today. First, this section deals with the production of decision aids, setting quality for decision aids that I mentioned earlier, creating shared decision-making resource centers around the country, and to provide funds to providers for the development, use, and assessment of various shared decision-making techniques. Now, as you know, some parts of the Accountable Care Act were actually, all of it was passed, but not all of it was funded. So this part has not been funded, so it kind of sits on the books as something we might do at some point, or maybe not. The other part of the Accountable Care Act that is funded is the so-called CMS Innovation Center. CMS is the Center for Medicare and Medicaid Services that Don Berwick heads, and they were given language in the law to test innovative payment models to reduce costs and quality using 18 different approaches. One of the approaches was assisting applicable individuals in making informed healthcare choices by paying providers for using decision support tools. Yes, paying providers to use decision support tools. So CMS is thinking of ways to try to incentivize physicians or provider organizations to use shared decision-making tools that can actually enhance information and medical options for patients. So this is kind of in the pipeline, and we're seeing some pilots emerge. Some of the notable pilots include the Palo Alto Medical Foundation, which is right across the street from where I work. It's a large multi-specialty group practice model that's part of the Sutter healthcare system. And they have embedded in their electronic medical record something they call the Shared Decision-Making Navigator. So when a physician is with a patient, they can refer the patient to the navigator, which is a part of the patient portal on the web. There's information and resources. They can actually make an appointment with a coach, and there's a library of online decision aids. Another model is at UC San Francisco in their breast cancer center. Every woman that's referred to the breast cancer center at UCSF receives a high-quality decision aid prior to her visit. After she's had a chance to review that, she has, when she arrives at the clinic, her first meeting is with a health coach who sits down and helps her construct the questions that will be part of the visit when she comes. So when she comes in to see the oncologist, she's already at a level of information and has questions and concerns ready to start that conversation. Massachusetts General Hospital has also had this approach of embedding decision aids in their electronic medical record so that you can actually prescribe it. So you can prescribe a medication, you can prescribe a decision aid so that patients can get it distributed to them. So these are some of the pilots that are occurring, and I hasten to add that some of it's driven by the desire to enhance patient experience, some of it's driven by this notion that shared decision-making actually may help them rein in resource use. And I do hope that some of it's driven by the fact that it's the right thing to do. Certain states have mandated shared decision-making, most notably Maine, Vermont, and Washington, and that's led to furthering of efforts in those areas, and other states are considering this as well. So lastly, I want to talk about what what we can all do to promote shared decision-making. And I'll share with you a few specific strategies which I believe can help enhance shared decision-making at both the individual patient level and at the health system level. First is to just begin with finding out from patients how much they want to be involved in decision-making. And as you saw, The vast majority of people want to be involved, but not everyone. And even having that conversation can be a great opener to involving the patient and having them feel that their views, their values and preferences are to be respected. The second is to use a very simple method known as teach-back. We'll come back to that in a moment. But teach-back in a nutshell is a way of having the patient explain back to the physician the information that's been provided to help you understand, help you find out if they've got a good working understanding of that information. Develop time-efficient scripts. One of the most common barriers that I hear from practicing physicians around shared decision-making is, well, it all sounds well and good, Clarence. It's the right thing to do, and there's evidence for it, but who has the time? So coming up with time-efficient approaches is one important part of this work. Using high-quality decision aids, which we've talked about, and to advocate for some of these strategies to be taken up in your own institution. So with regard to finding out your patient preferences, I cited this study earlier, and this shows the actual tool that they use. It's not very high-tech to find out from patients about their decision-making style. That ranges from a very active role. I prefer to make decisions about which treatment I will receive. There's a collaborative role. The doctor and patient make decisions together. And the more passive role. I prefer to leave all decisions regarding treatment to my doctor. It's helpful to just have that conversation. And some health systems have started to do this as part of a patient questionnaire. Your health history, where do you work, what's your preferred decision-making style, as a profile. And it's a helpful tool. Now I would caution that we've found that a person's preferred decision-making style may vary from one type of decision to another. And that's something we can talk about in the Q&A if there's time. The use of time-efficient scripts is something we've written about for prostate cancer screening, screening mammography, colorectal cancer screening, and I've even done some work with orthopedists around how to incorporate shared decision-making into a busy orthopedic practice. But phrases like, I'd like us to decide this together, to invite the patient to participate, how do you like to make decisions? If you don't use a little card, you could ask a question like that. I've covered a lot. Just to make sure I was clear enough, tell me what you heard me to say. There's a way of kind of getting back from that patient, that sort of teach back, to find out if they've really gleaned the key elements of the information that you've provided. Some people like to go with treatment A, give some reasons. Others like to go with treatment B. Which way are you leaning? Again, a way of inviting the patient's preferences, their values, how they're thinking about that decision, so that you as a physician can have a sense. Also, this notion of this might feel like a big decision. Maybe it's a surgery. Who else would you like to help you make this decision? A way of allowing people to reach out to trusted others, family, friends, colleagues, primary care physician. Now, the case at which we heard earlier, the prostate cancer screening example, I'm interested to hear what people's thoughts are about that. I hope that that example highlighted for you the importance of shared decision-making, the compelling ethical foundations, that it's a superior alternative to informed consent, the legacy that came from the law into medicine, that it's supported by evidence, patients want to be involved for the most part, there's strong evidence that shared decision-making can enhance the quality of clinical outcomes, and that we have to do something about this gap between this ideal and reality. And to make you aware of some of the changes in the policy and practice environment that make shared decision-making even more salient today than it has ever before. So as you think about that example of the physician trying to do his best to inform the patient about prostate cancer screening, think about how that could be improved upon. And think about the ways in which we individually can help enhance the involvement of patients in decision-making about their health. Thank you very much.
Thank you very much. That lecture was very well organized and had good information. I actually am a palliative care physician here. We do a lot of this exchange with the patient. And it does take a lot of time, and it takes specialty training. Yeah. And I noticed that with your affiliation with the medical school and these mandates that an answer to improving shared decision-making is, or one answer is decision-making tool. Yeah. Another is getting an intermediary to help enhance communication from the patient's part what are we doing at a medical education level to improve doctors' and physicians' communication skills so that they can they actually have the tools in order to do this?
Yeah, no, it's a great question. Just to paraphrase for the sort of the viewers at home, I think that the question is really all these developments that are sort of happening around the physician, and versus what are we doing to help physicians do a better job. And I think I've been troubled by this for a long time because, in a sense, it sort of suggests that physicians can't be remediated, which may be true, but I don't like to think that. But yes, I think there's been a lot more emphasis on teaching, in general, effective communication skills. I know a lot of your colleagues working on sort of having difficult conversations around, breaking bad news, goals of care conversations, and that work's been very important. And I think in both medical school and residency, more attention to that needs to be paid. There is one system I didn't mention, Group Health Cooperative in the Washington area, which also has made a major investment in shared decision making, the decision aids, the coaches, all the stuff around the physician. But they also did something I thought was very interesting. I haven't heard the results, but they had every single group health physician go to a half-day retreat to be trained in shared decision making, not just about it, but how to do it, using video trigger tapes and discussion, and I thought it was a pretty bold move, and I think that probably we need to think about the ways to promote that kind of investment. I'm doing a project with a group of orthopedic surgeons who more or less have given up on the orthopedic surgeons. They're using decision aids and coaches, and in fact one of the outcomes of the study is to see if the orthopedic surgeons are happier by not having to answer so many questions. So, I mean, it's a really important and challenging issue. I think that we shouldn't ignore the physician behaviors and providing for them both the skills but also the mindset to want to have those kind of conversations. Yes, sir.
Has the advent of the hospitalist enhanced the therapies?
That's a great question too, is whether the advent of the hospitalist has helped or hindered. It's a great, well, a couple things to say about that. I think hospitalists, obviously, as many of you know, the field arose because of the increasing challenge for practicing physicians to have an office practice and to see their patients in the hospital, and rather to hire physicians who would specialize in the care of inpatients in the hospital. And there are pediatric hospitalists, there are adult hospitalists, there are critical care hospitalists. The challenge is that one challenge I think that's embedded in that, in your question, is that increasingly these are relationships, the doctor-patient relationship in that setting is one between strangers. One between strangers. And that makes it more challenging to have a very casual and often intimate dialogue with the patient. It puts more onus on the physician to actually find ways to establish a bond in a short period of time. Interestingly, sometimes when physicians are strangers to their patients, they actually do a better job. Now, some of the early work I did comparing internists in the office with surgeons in the office in shared decision making, the surgeons pretty much consistently outperformed the internists in terms of the kind of research with the audio taping that we did. And one part of that was that because of the procedure focus, it had been sort of drilled into these surgeons that they needed to get consent, so they were much more kind of thinking about the importance of being very explicit about information. So I don't know that there's any research to answer that question, but I think it's a really interesting one that we should look at. And I certainly think that hospitalists run the risk of having a much more distant kind of relationship with patients. And I know that's something that the hospitalist groups are actively working on. Yes, sir.
One of the things I think is missing in the education of the younger students and the younger physicians, and 3 years of the PRC, you come in and patients will tell you that this doctor doesn't care. He sticks his head in and he says hello. If you walk in, sit down and relax and act like you've got all day, your patient will tell everybody that you're the greatest doctor that ever lived. You don't have to know a whole lot.
Yeah.
Sit down and relax and let them know they care.
Yeah.
Then they're going to start coming out with their fears.
Mm-hmm.
It's going to help you even more and help them through this decision, because they've got a whole family that have all decided, you know, one son may want to go on that and get their money, and you don't know what they're going through.
Yeah.
Just sit quietly, just for a few minutes, you get more information than going through all this other stuff.
Yeah.
You've seen it.
Yeah.
And they'll swear by it. I had one lady, I covered for a doctor. I went in, I think because he had surgery. I went in and introduced myself, and she asked me if I would have known. I mentioned my father, and I said, yes, that was my father. And she started off, said, oh, until I married my best friend's husband, I loved your father more than anybody ever knew. She said she told she had colon cancer. Her friend asked my father to see her. He walked in, introduced himself, pulled up a chair, and sat down. She said, I could feel myself. My father died at 67. When I saw her, she was 96 and still kicking.
No, that's a wonderful story, and I think, you know, the notion that you share, which again I'll just paraphrase, that, you know, does the modern physician, particularly young physician, do they recognize the importance of being present, of actually sitting down and being a good listener? And I think a lot of people share that concern. The example that, you know, in that audio clip that I played, on the one hand, some audiences have thought that he did a pretty good job giving a good explanation, but it's also, there's a lot of talking. Yeah. And the notion that good communication oftentimes involves listening. One of my favorite little bits of sort of evidence is the evidence around the time. If you look at, when you audio tape office visits, and you go from the time the physician makes his or her first question, so what brings you to the office today, and the patient starts to talk, how long it is before the physician interrupts with a closed-ended question, and it's less than 17 seconds. That's about how patient we are. There might be some finger tapping in that 17 seconds too, I'm not sure, but so I think we're part of the training needs to be understanding not only the importance of listening, which I think is your point, and so the notion of waiting even 34 seconds, just doubling it, communicates to the patient that you actually want to hear what they have to say, not the least of which, and also you actually may hear what you need to hear without asking all those pointed questions. So I think you're absolutely right.
I have a question about reducing health inequities in shared decision making. There's a lot of issues surrounding numeracy or literacy concerns, or language barriers.
Yeah.
How do you suggest shared decision making would improve that?
Yeah. Well, I have a colleague at University of Chicago, Monica Peak, who's done some work on this with focus groups, and what they found two things, and I'll come back to the numeracy literacy issue because I think the question is, how could shared decision making really impact disparities? One is that the act of having a conversation with patients, so she interviewed African American patients in Chicago who were in a diabetes clinic, and what she found is that when physicians gave them information, asked their opinions, even if they weren't quite sure what the physician was talking about, it communicated to them something that made them trust the physician more. They're more likely to follow through on the health recommendations, et cetera, et cetera. So that's one channel that she sort of suggests that could enhance and maybe reduce disparities, enhance quality, reduce disparities. The numeracy and literacy, and again, I'm no expert in this area, but I know that a lot of people are working on how to communicate risk, particularly risk information, in ways that can adapt to a pretty high percentage of our population that has limited health literacy. So, for example, rather than using numbers like percentages or risk ratios, to use the little stick figures, and that's something you've probably seen, where if you want to communicate how many people, what's the risk of having a complication from a medication, a visual that shows 100 little stick people that are all gray, and the ones who are going to say have bleeding from warfarin would be colored red. And they've found that people are better able to understand different ways of promoting risk information. There's also some interesting work and sort of cognitive sciences around a notion that's known as gist knowledge. So gist knowledge, is, like the name implies, is sort of the difference between knowing something verbatim and sort of having the gist of it. And what the research is suggesting is that patients really don't want or need verbatim knowledge of what the physician has to say. in order to participate effectively. They kind of just need to know the gist. And I always think of the example of if I take my car to the mechanic, and the mechanic, gets under the hood and says your gobbledygook is misconnected, misfiring, and your whatchamacallit. And I say, oh, okay. And he explains it, and I consent to getting it fixed. And I go home, my wife says, oh, you get your car fixed? Yeah, the car's fixed. It's working like a charm. What was wrong? Well, there was something with something or other, but it made sense at the time. It made sense at the time. So it's sort of just knowledge. So I think it's an interesting concept because we may not need to work as hard at finding ways to pump huge amounts of information, but ways to sort of reframe it into the gist and other ways of framing risk information.
It dovetails actually with your comment just now, but it has to do with the shared decision-making part. That's how much you wish to be part of the decision as a patient. And it went from, I want to be intimately involved as opposed to, I want the doctor to make the decision. And I've talked both with the medical students and the master's students about the whole notion of autonomy waiver. Waive our right to have information. But one of the things that I've often embedded in that little mini lecture has to do with if you waive your autonomy, it must be waived to another person. That person must not be the physician. That the physician then would be holding all of the cards, and that you need to have a family member or loved one who will make decisions for you. The concern then is if you have a decision-making device or aid where it says, okay, I want you to make all the decisions for me. And the doctor would be saying, well, here's the new medicine, here, hypothesize, or whatever, without having the opportunity to say, if this, then you must have someone else involved. Do these decision aids have some sort of embedding to protect the patient from their ready obedience if they're ready to waive their autonomy? So there's going to be a respected, trusted other who's not the physician to protect their interests.
This is the problem with having one of your colleagues in the audience. They ask you really, really hard questions. That's a really good point. The nuance, I think, between a person who's adopting a passive decision-making style and a person who's abdicating their autonomy. And I think you're spot on there. I think what the response, if I were to channel those investigators, they would say that the patient still deserves to have an invitation to be given information, and if at the end of that they say, well, what do you recommend? And they're going to be passive to that recommendation. That's different than the person who says, I want you to decide. Now, I may not convince you, but I think you're essentially right. And I think the other thing I would say that has troubled me about the sort of autonomy preference is that, and again, there's some empirical evidence of this, that people's desire for autonomy for decisions varies from decision to decision. People who argue vociferously and come in with magazine articles about their cholesterol medication, and then when it comes time for them to, they need a surgical procedure, they'll just say, just do what you need to do. And so I think that's another challenge. So I think you're right, and I guess I would say that we probably need to be a little bit more nuanced in our distinction between, maybe being more passive. And there's the danger of passivity, I think, that you're speaking to, is that the physician may inadvertently conclude that they just have licenses to be very paternalistic.
I guess the caution is that the shared decision-making, and the patient is saying, I don't want to make the decision, that it must be shared between the physician and someone else.
No, I think that's right. It should be shared with someone else. Yes, sir.
After listening to physicians for a long time on the ethics committee and the IRB, the one thing I'm hearing more often than anything else is physicians are not sharing the bad news. At your age and with the multiple maladies you have, prospects are not good. With third and fourth stage metastatic cancer, the treatment is aggressive, it is painful, your quality of life is going to be awful. In the studies, there's little evidence this might help. There's no evidence that it's going to help, or we wouldn't be doing the study. And what's not being shared is the patient, obviously with the placebo effect and all of that, is, it's your decision to make, but they're not seeing how desperate their decision is.
No, I think it's a poignant example of, And I've done some work on shared decision making and sort of end of life and ICU. The question I think is there a problem with physicians for us as a profession being reluctant or unwilling or uncomfortable sort of giving the bad news, the downside, or when the treatment's not likely to work? And I think that's true. I think that's a true statement. And I think a lot of I obviously do a lot of work in clinical ethics, and a lot of the consults that I get called in on are where the train has been running down the track pretty much full steam, and no one's been willing to say that the bridge is out, and so. But I think the gap, and again, my palliative care colleague over here might have something to add to this, that sometimes I think our role as consultants is helping people find language with which it's comfortable to say the things that they know they need to say, or if they can't, to channel what they're thinking into something that helps the patient family to understand the reality of the situation. I don't know if you have anything you want to add to that.
I just think that palliative care could be seen as a model for shared decision making and end-of-life decisions. And I think that here at University of Louisville we have a mandatory 30-year clinical experience in clinical palliative care. And I really have seen that these students have a greater appreciation after they've been through palliative care for the importance of just establishing how you make decisions and how that shared decision making occurs, especially with cultural sensitivity and consideration of pros and cons, and not to be afraid to talk about the cons. I really think that palliative care could be the answer to teach our future physicians how to be prepared to have shared decision making.
So I think that's right, and I appreciate that additional. So I would say that in these last few questions are causing me to reflect on Dr. Chang, and from what I of course didn't have the honor of knowing him, but from what I've heard about him, I think the notion of the courage and integrity of physicians to be able to do what we need to do even when it's difficult. And shared decision making is one of these areas that is challenging, particularly at the end of life, particularly in situations of urgency, particularly when patients have literacy and numeracy barriers. But I think the work we have to do ahead is to find effective ways to do what we know we should be doing with every single patient for important clinical decisions. And I hope that my comments today have given you some thoughts and ideas of how to pursue that. Thank you very much.
Thank you very much.